first topic is examination of acute abdomen. Acute abdomen basically means the patient complains of an acute attack of abdominal pain that may occur suddenly or gradually over a period of several hours and presents a symptom complex which suggests a disease that possibly threatens life and demands an immediate or urgent diagnosis for the early treatment. A careful history should be taken indicating the symptoms of the patient and a careful examination to find out the physical signs and their interpretation, which are of high significance to come to a diagnosis in these cases. It goes without saying that how important it is to make the diagnosis as early as possible in this condition. Delay will definitely worsen the condition of the patient and may lead to fatal outcome. History क्या करोगे? Age. A few acute abdominal conditions are peculiarly seen at a definite age group. In newborns, intestinal obstruction due to intestinal atresia, stenosis, meconium ileus, meconium peritonitis, imperforate anus, and annular pancreas are commonly seen. In infants, midgut volvulus intussusception and Meckel's diverticulitis are common. In children, appendicitis, non-specific mesenteric lymphadenitis, primary pneumococcal or streptococcal peritonitis, and roundworm intestinal obstructions are commonly come across. In young adults, appendicitis and Meckel diverticulitis are common. In adults, perforation of peptic ulcer, acute cholecystitis, acute pancreatitis are more common. In elderly, sigmoid volvulus intestinal obstruction from malignant growth, diverticulitis, and mesenteric occlusive disease are common. Sex, ruptured ectopic gestation, twisted ovarian cyst, acute salpingitis are obviously the disease of women. जैसे कि ruptured ectopic gestation, twisted ovarian cyst, acute salpingitis are obviously the disease of women. But a few acute abdominal conditions are peculiarly more often seen in the females than men. But a few acute abdominal conditions are peculiarly more often seen in females than males. These are acute cholecystitis, acute appendicitis, primary peritonitis, cholecystitis, appendicitis, and peritonitis. Whereas perforation of peptic ulcer, pancreatitis, volvulus intussusception, etc. are more common in male. Occupation. Painters may have a recurrent abdominal colic due to lead poisoning. Recurrent abdominal colic due to lead poisoning. Similarly, workers in arsenic industry suffer from similar disease. Residence. Peptic perforation is common in northern India and southern and in southern India due to their habit of taking very spicy food. Acute cholecystitis is common in eastern India and southern India. Acute cholecystitis is more common in eastern India and southern India. Amoebic typhlitis is only seen in tropical countries. Pancreatitis is more common in western countries due to their habit of consuming alcohol. Then appendicitis is more common in western countries due to their habit of taking low residue diet. Appendicitis is more common in western countries as low residue diet, यानी कि रफेज कम खा रहा है. Social status, appendicitis is more common in high income group, probably tend to take more protein as the main dish, exactly what I said, low residue diet, and ignore vegetables. Peptic perforation is more common in low income group as they tend to ignore peptic ulcer disease at an early stage. Chief complaints, time of onset. The pain of acute appendicitis starts in the early morning, whereas sudden pain due to perforation of a peptic ulcer usually takes place in the afternoon after the lunch break, but the patient is often brought to the hospital at night. The pain of acute appendicitis starts early in the morning, where sudden pain due to perforation of a peptic ulcer usually takes place in the afternoon after the lunch break, but the pain is brought to hospital at night. Mode of onset. This is sudden perforation, colic, torsion, volvulus, etc. Sudden in perforation, colic, torsion, and volvulus, etc. In acute intestinal obstruction, the pain may not be severe at the onset but gradually increases with intensity. In acute appendicitis, the pain becomes boring in the beginning and suddenly becomes acute in the case of obstructive appendicitis, which often wakes up the patient early morning. Acute abdomen is sometimes precipitated by administration of purgatives, that is acute appendicitis, by straining, example perforation, or jolting, ulcerative colic. How long is the history of presenting complaint of the pain? Similar type of pain with the varying intensity appearing on and off for last few years is a feature of appendicitis, cholecystitis, etc. In peptic ulcer, periodicity is noted before the perforation. Site of pain, it is usually coincides with the position of the affected. Hello. ओके ओके, मैं देखता हूँ. 28 को भी संडे है ना? हाँ वही हम चेक किया. हाँ देखें हैं.
देखो चेक करो. 28 फ्राइडे है, 29 सैटरडे है, 30 को संडे है. चेक करो. ये
29 संडे है, 28
हाँ
28 ठीक है, हम 28 का सुबह का देखते हैं। ओके
हाँ हाँ, ये 27 को डेट देख लो।
ठीक है।
हाँ, या अर्ली मॉर्निंग भी है 28 को।
ओके।
ठीक है, ठीक ठीक।
How long is the history of presenting complaint of the pain? Similar type of pain with varying intensity appearing on and off for the last few years is a feature of appendicitis, cholecystitis, etc. In peptic ulcer, periodicity is noted before perforation. In peptic ulcer, periodicity is noted before perforation. Site of pain, it usually coincides with the position of affected organ. The patient is asked to indicate the site of pain with the tip of one finger pointing test. If the pain is diffuse, the patient will always use the whole hand instead of one finger to locate its side. If the pain is at the flank, renal origin is considered. When it is below the right costal margin, it means liver or gallbladder suspected. If it is in the epigastric region, peptic ulcer, perforation, acute pancreatitis, etc. are considered. Shifting of pain, this is a characteristically seen in acute appendicitis. Acute appendicitis में shifting of pain होता है. The pain is initially felt around the umbilicus but later on shifts to the right iliac fossa with the onset of parietal peritonitis. पैरेटल पेरिटोनाइटिस हो जाएगा तो राइट इलियक फोसा में चल जाए. रेडिएशन ऑफ पेन, इट इज़ शिफ्टिंग या फिर माइग्रेशन ऑफ पेन है. रेडिएशन ऑफ पेन इसका मतलब इफ द इन स्प्रेडिंग पेरिटोनाइटिस द पेन इज फर्स्ट कंप्लेंड ऑफ एट द रीजन ऑफ अफेक्टेड ऑर्गन बट एज सोन इट स्प्रेड ऑल ओवर द वुमन abdomen. In case of peptic perforation, figure 33.1, the patient is asked to show the site of pain with one finger. The figure shows typically pain the site of shows the typical site of pain. Iliac fossa as the gastric contents gravitate down in the case of peptic ulcer. Pain is felt at the right hypochondriac region but soon is radiated towards the right. At this time this condition mimics the appendicitis. When the patient complains of radiating pain from towards the left iliac fossa while he is suffering from acute appendicitis, the condition is of one of spreading peritonitis. Referred pain. The pain is said to referred when it is felt at some other regions having same segmental information as the site of lesion. It says to the T5 to T8, stomach, duodenum, jejunum, T5 to T8. The pain is felt in the epigastrium in affections of ileum and appendix T9 and T10. Okay, ileum हो गया T9 और appendix हो गया T10 around the umbilicus, whereas in case of colon T11, T12, L1, L2 in the hypogastrium. T11, T12, L1, L2 हो गया hypogastrium. The diaphragm is supplied by the phrenic nerve C3, C4, C5, of which main supply comes from the fourth. The cutaneous nerves on the same segments are concerned in supplying the skin over the shoulder as also the upper part of the front of the chest through supraclavicular nerves C3 and C4. Any irritation, the cutaneous nerves from the same segments are concerned in supplying the skin over the shoulder as also the upper part of the front of the chest through supraclavicular nerves C3, C4. Any irritation on the undersurface of the diaphragm either by gastric contents or blood or bile after operation of the biliary tract or inflammatory exudate may give rise to referred pain to corresponding shoulder. The cutaneous nerve supply from the segments are considered concerned in the supplying the skin over the shoulder as also the upper part of the front of the chest through the supraclavicular nerve C3, C4. Any irritation on the undersurface of the diaphragm either by gastric contents or blood or bile, bile matlab after operation on the biliary tract or inflammatory exudate may give rise to referred pain to the corresponding shoulder. In suspected cases, of foot end of the bed may be raised by about 18 inches to allow exudates to gravitate down towards the undersurface of the diaphragm, which will obviously initiate pain on corresponding shoulder. In renal colic, the pain is referred from the loin to groin, testis, and inner side of thigh. That is distribution of the genitofemoral nerve L1, L2. The same segment supply the ureter also. In biliary colic, the pain radiates from the right hypochondrium to inferior angle of the right scapula. Biliary colic, the pain radiates from the right hypochondrium to the inferior angle of the right scapula, since the gallbladder is supplied by the 6th, 7th and 7th to 9th nerve thoracic segments. In passing, it must be emphasized that the segmental nerve supply, as has been referred to in this section, is sympathetic supply of the viscous Of course, the same viscous also receives the parasympathetic supply mostly from the vagus, the sole exception being the hindgut and the bladder, which receives sacral sympathetic supply. Similarly, irritation of the parietal pleura or may occur in pleurisy. Hemothorax or pneumothorax may initiate referred pain to the abdominal wall, as may mimic acute abdominal conditions. Similarly, irritation of the parietal pleura, as may occur in the pleurisy, hemothorax or pneumothorax may initiate referred pain to the abdominal wall, as may mimic acute abdominal conditions. Character of pain, colicky pain. It is a sharp, intermittent, gripping pain which comes on suddenly and disappears suddenly. It indicates obstruction to a hollow organ, either bowel obstruction, intestinal colic, or obstruction of the common bile duct with a stone, biliary colic, or obstruction of the renal pelvis, or ureter with a stone, जैसे कि urinary or ureteric colic. Constant burning pain is a feature of peritonitis and often performed in a perforated. Constant burning pain is a हो गया perforated ulcer, peptic ulcer. Severe agonizing pain is much characteristic of acute pancreatitis or of torsion. Severe agonizing pain is a very much characteristic of acute pancreatitis or of torsion. Throbbing pain is suggestive of inflammation, example hepatitis or cholecystitis. Throbbing pain is suggestive of inflammation, example hepatitis or cholecystitis. Change in character of pain is sometimes noticed. Colicky pain of acute intestinal obstruction may change into constant burning type, which indicates strangulation. Change in the character of pain is sometimes noticed. Colicky pain of the acute intestinal obstruction may change into constant burning type, which indicates strangulation. Diminution of pain is not always a happy symptom. In acute appendicitis, it may indicate perforation of an obstructive gangrenous appendix. In acute appendicitis, it may indicate the perforation of an obstructive gangrenous appendix. In second stage of irritation of peptic perforation, pain diminishes in intensity although the disease is continuing. This is due to the fact that peritoneal exudate dilutes the irritant gastric content. Effect of pressure on pain. In colics, pressure gives relief, but in inflammatory conditions aggravates pain. Colics में pressure gives relief, but inflammatory condition में aggravates the pain. Relation of the pain to jolting, walking, respiration, and micturition. In amoebic hepatitis, cholecystitis, and appendicitis, the pain aggravates during walking and jolting. Amoebic hepatitis, cholecystitis, or appendicitis, pain aggravates during walking and jolting. Ureteric colic sometimes gets worsened by jolting. In diaphragmatic pleurisy, pain is aggravated during deep inspiration. Diaphragmatic pleurisy, pain is aggravated during deep inspiration and coughing. Pain during act of micturition or strangury is frequently met within ureteric colic, pelvic appendicitis, or even pelvic abscess. What makes a pain better or worse? In case of peritonitis, pain is slightly relieved if patient lies still. If he rolls about, the pain becomes worse. In case of pain due to diaphragmatic irritation due to either inflammatory exudate or due to blood from injury out to the liver or spleen, deep inspiration will aggravate the pain. In case of cholecystitis, fatty foods will aggravate the pain, whereas fat-free diet will give some relief. In case of cholecystitis, fatty foods will aggravate the pain, whereas fat-free diet will give some relief. Cholecystitis में fatty foods will aggravate the pain. In case of pain due to diaphragmatic irritation, either due to inflammatory exudate or due to blood from injury, liver or spleen, deep inspiration will aggravate the pain. In case of cholecystitis, fatty foods will aggravate the pain, whereas fat-free diet will give some relief. In case of peptic ulcer, alkalis will make the pain better, whereas alcohol, spicy food or drugs like aspirin will aggravate the pain. In case of hiatus hernia and reflux esophagitis, stooping will make the pain worse. How is the pain relieved? Vomiting sometimes relieves the pain in peptic ulcer. In colics, vomiting temporarily relieves the pain which reappears immediately. In acute pancreatitis, the pain is relieved to a certain extent by sitting up from the recumbent position. Application of local pressure relieves colicky pain. Biliary or intestinal. Vomiting. Character of the act. The vomiting may be projectile, that is involuntary forceful ejection of a large quantity of vomitus in high intestinal obstruction, toxic enteritis, etc. In case of peptic ulcer, perforation, or general peritonitis, the vomiting is quite regurgitation of mouthfuls. Vomitus. In intestinal obstruction, at first the stomach contents, next the duodenal contents, bilious, and lastly the intestinal contents, feculent, are voided. In intestinal obstruction, at first the stomach contents, next the duodenal contents, bilious, and lastly the intestinal contents, feculent, are voided. True fecal vomiting is not common. True fecal vomiting is not common. It is seen in gastrocolic fistula. In case of biliary colic, the vomiting is usually bilious. In case of peptic ulcer, the vomiting is usually nothing but gastric contents. In late cases of peritonitis, the vomiting becomes dark brown, feculent, mixed with altered blood. This type of vomiting is also seen in uremia. Frequency and quantity. Vomiting is constant, frequent, and profuse in acute intestinal obstruction and acute pancreatitis. Acute intestinal obstruction और acute pancreatitis में constant and frequent and profuse होता है. In peptic ulcer, vomiting is periodical. In perforation of a peptic ulcer, vomiting is not a diagnostic feature. In perforation of a peptic ulcer, vomiting is not a diagnostic feature. In perforation of a peptic ulcer, vomiting is not a diagnostic feature. It may be once or twice during the first stage. It is more or less absent in the second stage and may reappear in the last stage with the characteristic vomitus of different peritonitis. In perforation of a peptic ulcer, vomiting is not a diagnostic feature. In perforation of a peptic ulcer, vomiting is not a diagnostic feature. It may be once or twice during the first stage. It is more likely or less absent in the second stage and may reappear in the last stage with the characteristic vomitus of diffuse peritonitis. Similarly, in the acute appendicitis, it may or may not be present. Acute appendicitis may or may not be present, but nausea is more often complained of. Both nausea and vomiting are characteristic complaints of pre and post ileal appendicitis. In relationship with pain precedes vomiting in acute appendicitis, acute pancreatitis, peptic ulcer, biliary and renal colics. In high intestinal obstruction, the vomiting appears almost simultaneously with the pain. In obstruction of the lower end of the ileum, vomiting may not occur in the beginning but follows after a few hours. In large bowel obstruction, vomiting is absent. Large bowel obstruction में vomiting is absent. Okay, in obstruction of lower end of ileum, vomiting may not occur in the beginning but follows after a few hours. In large bowel obstruction, vomiting is absent or is a late feature. In large bowel obstruction, vomiting is absent or is a late feature. So first, okay, in obstruction of the lower end of the ileum, vomiting may not occur in the beginning but follows after a few hours. In large bowel obstruction, vomiting is absent. Large bowel obstructions, vomiting is absent and or is a late feature. Vomiting relieves pain in case of peptic ulcer, but in colics it relieves pain. Vomiting relieves pain in case of peptic ulcer, but in colics it relieves pain temporarily so that it appears immediately. Bowel habit, absolute constipation, that is arrest of both feces and flatus, is usual complaint of the intestinal obstruction and peritonitis. A history of one motion in the beginning of intestinal obstruction is not unusual. Okay. In acute appendicitis, the history of constipation is often received. A history of one motion in the beginning of intestinal obstruction is not unusual. In acute appendicitis, the history of constipation is often received. In pelvic appendicitis or pelvic abscess, irritation of the rectum may lead to tenesmus. In pelvic appendicitis or pelvic abscess, irritation of the rectum may lead to tenesmus. That is ineffectual straining at stool with passage of mucus and blood. In children, features of intestinal obstruction accompanied by passage of mucus and blood per annum is suggestive of acute intussusception. In children, features of intestinal obstruction accompanied by passage of mucus and blood per annum is suggestive of acute intussusception. In mesenteric thrombosis, so in acute appendicitis, history of constipation is often received. In pelvic appendicitis or pelvic abscess, irritation of rectum may lead to tenesmus, that is ineffectual straining of stool with passage of mucus and blood. In children, features of intestinal obstruction accompanied by passage of mucus and blood per annum is suggestive of acute insufficiency. In children, features of intestinal obstruction accompanied by passage of mucus and blood per annum is suggestive of acute intussusception. In children, features of intestinal obstruction accompanied by passage of mucus and blood per annum is suggestive of acute intussusception. In mesenteric thrombosis, blood and putrid stool may be noticed. Diarrhea occurs in acute or ulcerative colitis, regional ileitis, and acute enteritis. Micturition strangury, that is painful and frequent attempts at micturition or passing only a small quantity each time, is often come across in the case of stone impacted in the lower end of ureter and stone in the bladder. In inflammatory conditions in the neighborhood of bladder and ureter, such as retrocecal appendicitis, pelvic appendicitis, and pelvic peritonitis, they may give rise to the same condition. Even retrocecal appendicitis lying in very close proximity to ureter may lead to hematuria, which may mislead the clinician. Even retrocecal appendicitis lying very close proximity to ureter may lead to hematuria, which may mislead the clinician. Personal history of women, the menstrual history is very important and should be never missed. A history of missed period is often present in the rupture of ectopic gestation. If a patient presents with symptoms very much similar to acute appendicitis in the middle of a menstrual period, one should suspect ruptured follicular lutein cyst. Smoking and alcohol should always be inquired into. Past history of perforation of peptic ulcer, previous history of ulcer pain may be elicited. Even there may be a history of hematemesis and melena. In suspected cases of acute appendicitis, biliary and renal colics, history of previous attacks may be presented with the patient may consider to bear no relation with the present illness. In intestinal obstruction, one may get a history of previous abdominal operation. Past history में perforation of peptic ulcer, previous history of ulcer pain may be elicited even if there is a history of hematemesis and melena. Peptic ulcer. In suspected cases of acute appendicitis, biliary and renal colics, history of previous attacks may be presented with the presented which the patient may consider to bear no relation with the present illness. Intestinal obstruction, one may get a history of previous abdominal operation. Acute cholecystitis, there may past history of biliary colic, high rise of temperature and jaundice. That is Charcot's triad. Okay, then comes physical examination. General examination. Appearance in acute abdominal patient presents with a peculiar facial symbol abdominal faces which helps the clinician to discriminate the normal from the extra-abdominal case. In the normal stage of peritonitis, the facial hypocratica can be observed. In an anxious look, bright eyes, pinched face, and a cold sweat on the surface are features of this type of faces which once seen will never be forgotten. Faces of dehydration is also typical and consists of sunken eyes, drawn cheeks, and dry tongue. The peculiar lividity or blueness cyanosis of the face is a feature which is characteristic, though not often found in acute hemorrhagic pancreatitis. Extreme pallor and gasping respiration is a movement which bearing child should be suspicion of ruptured tubal gestation. Attitude colic में patient either is tossing on the bed, doubled up, or rolls in agony, seeking in vain a position of comfort. In peritonitis, the patient remains quiet and because movements will only increase the pain. Only in the last stage of peritonitis and post-operative peritonitis, the patient becomes highly excitable, which is evidenced by throwing of bedclothes, tossing of the head, grumbling, ineffective movements of the hands and feet, etc. Nothing needs to give comfort. Pulse. In early stage of many acute abdominal conditions, example acute intestinal obstruction, the acute hemorrhagic pancreatitis, perforation of peptic ulcer, the pulse remain normal in rate, volume, tension. But it is said to have a good diagnostic guide to in acute appendicitis. Sometimes the patient who cannot locate the pain properly, probably the pulse plays an important role. So far as the diagnosis of acute appendicitis is concerned, in internal hemorrhage, the pulse becomes immediately rapid. In peptic perforation, the pulse may become normal in the early stage, but with the spread of peritonitis, the pulse begins to quicken and becomes small in volume. In acute intestinal obstruction, though the pulse remains normal in the beginning, but with the advent of dehydration, the volume and tension fall and its rate increases with no tendency to return to normal. ठीक है? In acute intestinal obstruction, though the pulse remains normal in the beginning, but with the advent of dehydration of the volume and tension fall and its rate increases with no tendency to return to normal. Respiration. Bearing internal hemorrhage and late cases of peritonitis, the respiration rate may seldom be high in acute abdominal conditions. If the temperature becomes high, the respiration rate will proportionally be increased. Yes, temperature high तो respiration rate बढ़ेगा. Increased rate with the abdominals of alienacy should direct one's attention to the thorax as the seat of disease. Referred pain in the abdomen is quite common in lobar pneumonia. Basal pleurisy sector. Temperature in effective conditions, the temperature will be raised. This condition of temperature varies from the condition to abdomen to a condition to condition. This may be quite high in the case of acute appendicitis, particularly in children. In acute cholecystitis, it is raised to a moderate degree, whereas acute pancreatitis or an acute diverticulitis, the temperature may not be raised that much, but it is must be remembered that the rise of temperature is never an early sign. It occurs in the late stage. Example, in acute appendicitis, the pain often first followed by the vomiting. पहले vomiting फिर pain. फिर हो गया fevers come last of all, Murphy syndrome. Tongue, it is supposed to be an index of the state of digestive system. Note whether it is dry or moist coated or not. A dry tongue indicates dehydration. A dry and brown tongue signifies toxemia. Dry and brown tongue signifies toxemia. Even in early stages of appendicitis, it may be dry and thinly coated, as the patients might have vomited a good quantity. Anemia, cyanosis, and jaundice. Obvious pallor is seen in hemorrhagic conditions. Obvious pallor is seen in hemorrhagic conditions. यहाँ पर कि जैसे कि हो गया ruptured ectopic gestation. फिर क्या हो गया cyanosis is noticed in case of hemorrhagic acute pancreatitis. Cyanosis is noticed in the case of hemorrhagic acute pancreatitis. Jaundice is often noticed after biliary colic and occasionally in acute pancreatitis. Jaundice is often noticed after biliary colic and occasionally in acute pancreatitis. Jaundice is often noticed after biliary colic and occasionally in acute pancreatitis. तो जैसे jaundice है वो हमेशा biliary colic के बाद मिलेगा और occasionally acute pancreatitis में भी मिल सकता है. ठीक है, जॉन्डिस होगा बिलियरी कोलिक में के बाद. एग्जामिनेशन ऑफ द एब्डोमेन इंस्पेक्शन. तो पेशेंट शुड लाई फ्लैट ऑन हिज बैक विद लेग्स एक्सटेंडेड, द होल एब्डोमेन फ्रॉम द निपल्स above down to the saphenous opening, thus the inguinal femoral rings are exposed, must be exposed. Examination should be carried out in the good light, preferably in daylight. First inspect the hernial orifice. It is good practice to start from the bottom. This should have been the last part of inspection, but if the examination be left for the last, it may be missed and actual case of may remain in the dark. Hernial orifices. Okay. Contour of the abdomen. Distension of the abdomen in acute intestinal obstruction occurs gradually. Distension of the abdomen in acute intestinal obstruction occurs gradually and may not be evident till someone has elapsed. Distension of abdomen in acute intestinal obstruction may occurs gradually and may not be evident till someone has elapsed. Distension is central in case of small bowel obstruction, whereas it is peripheral in large bowel obstruction. In volvulus of the sigmoid colon and cecum, distension almost immediately appears. In volvulus of the sigmoid colon and cecum, distension immediately appears. In second stage of peptic perforation, slight distension may be evident. Second stage of peptic perforation, slight distension may be evident. Second stage of peptic perforation, slight distension may be evident. On the contrary to in biliary colic, second stage of perforation, slight distension may be evident. On the contrary, in biliary colic, acute cholecystitis, acute appendicitis, and renal colic, the contour of abdomen all remains normal. Distension. फिर आते हैं रेस्पिरेटरी मूवमेंट में. रेस्पिरेटरी मूवमेंट में हो गया स्लगिश और नो रेस्पिरेटरी मूवमेंट ऑफ द एब्डोमिनल वॉल इंडिकेट्स वाइड स्प्रेड पेरिटोनियम एज कॉज ऑफ द डिफ्यूज पेरिटोनाइटिस और हेमरेज इनटू द पेरिटोनियल कैविटी. Similarly, localized limitation of the respiratory movements occurs in localized irritation of peritoneum from inflammation of underlying organs. Example is acute cholecystitis और appendicitis. फिर आते हैं peristaltic movements में the characteristic ladder pattern peristalsis may be found in the small bowel obstruction. Watch for a while patient visual peristalsis. Look for pulsatile swelling in the case of leaking abdominal aneurysm. The patient may come with acute pain in the abdomen. Skin. Discoloration of the left flank, grey Turner sign. Discoloration of the left flank. जिसको कह रहा है grey Turner sign and bluish hue around the umbilicus, Cullen sign, or occasionally seen in the late cases of acute hemorrhagic pancreatitis with extensive destruction of the pancreas. Okay, are occasionally seen in the late cases of grey Turner sign and Cullen sign. Cullen sign हो गया umbilicus में ग्रे टर्नर साइन हो गया, लेफ्ट फ्लैंक में डिस्कलरेशन. Okay, this is in the late cases of acute hemorrhagic pancreatitis with extensive destruction of the pancreas. Sometimes there may be redness and even blisters on the skin at the site of pain. This is an indication of a hot application of the site of pain or to get relief. Palpation. During palpation, methods should be adopted same as those of measured chronic abdominal conditions. 2 points. The volar surface of the fingers are employed for palpation. The forearm should be kept horizontal along the level of abdomen so that the fingers are placed flat on the abdominal wall. They must not be held vertical to poke the abdominal wall. The rough palpation will lead to voluntary contraction of the abdominal muscle. Rough palpation will lead to voluntary contraction of the abdominal muscles of the patient, and this will definitely stand in the way of obtaining right information from palpation. The clinician must keep his hands warm before palpation of the abdomen. This will gain confidence of the patient. Hyperesthesia हो गया. Sometimes cutaneous hypersensitivity can be obtained due to presence of inflamed organ underneath. This can be elicited by gently picking up the fold of skin and lifting it off the abdomen, or by simply scratching the abdominal wall with finger. Presence of hyperesthesia in Sharon's triangle. This is found by joining the lines of umbilicus, right anterior superior iliac spine, and pubis symphysis pubis. Presence of hyperesthesia in the Sharon's triangle is regarded as a good guide in the diagnosis of gangrenous appendicitis. Right ASIS, umbilicus and pubic symphysis. So that would be Sharon's triangle. वहाँ पे hyperesthesia is regarded as a good guide in the diagnosis of gangrenous appendicitis. If this hyperesthesia disappears during the process of illness, it indicates bursting of gangrenous appendix. An area of hyperesthesia between 9th and 11th ribs posteriorly on the right side is known as BOA sign. An area of hyperesthesia between the 9th and 11th ribs is BOA sign. An area of hyperesthesia between 9th and 11th ribs posteriorly on the right side is known as BOA sign. It is suggestive of acute cholecystitis. Tenderness is a constant over an inflamed organ. Tenderness is constant over an inflamed organ. Ask the patient to point at the site of pain. Pointing test. If this proves to be on the site of maximum tenderness, it is clearly the site of diseased viscus. In acute cholecystitis, tenderness is present just below the tip of ninth costal cartilage on the lateral margin of the right rectus. Tip of ninth costal cartilage on the lateral margin of the right rectus, and that is acute cholecystitis. Tenderness is present. In acute appendicitis, tenderness is present at the McBurney's point. The point is situated at the junction of lateral 1/3 and medial 2/3 of the right spino-umbilical line joining the right anterior superior spine. So spino and umbilicus. So umbilical. Spino-umbilical line, lateral 1/3 and medial 2/3. It is a good practice to ask the patient if to show pointing tests और कोस्टल राइट नाइन्थ कोस्टल कार्टिलेज का lateral margin of the right rectus. If he may twinge of pain may be felt over the inflamed area. Note carefully the degree and extent of tenderness. These indicate the severity of disease. In doubtful cases, one can easily be revealed by this. The pate is slightly moving, and this gastric contents. And this is also felt on the left iliac fossa, and spreading peritonitis demands immediate surgical intervention. Similarly, in the case of peptic perforation, tenderness may be elicited in the right iliac fossa. Tenderness may be elicited in the right iliac fossa as the gastric contents gravitate downward, grounded along the right paracolic gutter. Similarly, in a case of peptic perforation, tenderness may be elicited in the right iliac fossa as the gastric contents gravitate along the right paracolic gutter. Very often, a case of peptic perforation has been diagnosed as acute appendicitis due to presence of right iliac fossa tenderness. Very often, a case of peptic perforation has been diagnosed as acute appendicitis to presence of right iliac fossa tenderness. Appendicular tenderness can be elicited in the left lateral position. Appendicular tenderness can be elicited in the left lateral position when the viscera shift to the left, exposing the appendix to the direct palpation. When the viscera shift to the left, exposing the appendix to direct palpation. Okay. The abdominal wall becomes relaxed in this position. ठीक है, left lateral. Differentiation from thoracic disease, example diaphragmatic pleurisy or basal pneumonia often refer pain to the abdomen can be made by the fact that in this condition the skin may become aesthetic, but no definite tenderness can be elicited from depalpation. There further, if these cases complain of pain in the right iliac fossa and mimic appendicitis, pressure on the left iliac fossa will fail to elicit tenderness on the right iliac fossa, Rovsing sign, which is typically present in appendicitis, rebound tenderness. Blumberg sign or release sign, this is mainly a sign of peritonitis due to presence of an inflamed organ underneath it. The suspected area is palpated. With each expiration, the hand on the abdomen is gradually pressed down as the circumstances may allow. The hand is now withdrawn suddenly and completely. As a result of this abrupt removal, the abdominal musculature springs back onto its original place. As a result of this abrupt removal, the abdominal musculature springs back into its original place. The patient will immediately cry out or at least whines in pain. This is due to the fact that the parietal peritoneum, which has already been inflamed due to the presence of underlying inflamed organ, this is due to the fact that parietal peritoneum, which has already been inflamed due to the presence of underlying inflamed organ, also springs back along with the abdominal muscles. This sudden movement of inflamed peritoneum is very much painful. In presence of abdominal guarding due to generalized peritonitis, this test may not be necessary. Presence of this sign is an acute intestinal obstruction, suggests the strangulation of the gut. Rovsing sign. If the left iliac fossa is pressed, the pain is appreciated on the right iliac fossa in the case of acute appendicitis. Yeah, this is due to the fact that coils of the ileum shift slightly to the right and press on the inflamed appendix. This is a very important test to differentiate acute appendicitis from the other abdominal conditions. Cope-psoas test. Retrocecal appendix lies on the psoas muscle. Retrocecal appendix lies on the psoas major muscle. So, कोप टेस्ट में क्या कर रहे हैं? कोप psoas टेस्ट में the right thigh is being hyperextended, which will initiate pain in case of retrocecal appendicitis. Note the position of Sharon's triangle indicated by dots. Yes, Sharon's triangle, right ASIS, umbilicus or pubic symphysis. Eliciting Rovsing sign. Left iliac fossa is pressed and the pain is appreciated in the right iliac fossa in case of acute appendicitis. Method of eliciting Cope obturator test. Chaikor test है ये कोई. Inflammation of this appendix will cause irritation of the psoas major muscle, which is concerned with the flexion of the hip joint. When the right hip joint of the patient is hyperextended, this muscle is stretched. Psoas test. Okay, so this will initiate the pain in the case of retrocecal appendicitis. The patient is turned to the left and right thigh is hyperextended. लेफ्ट में उसको घुसा दिया और राइट थाई को हाइपर एक्सटेंड करेंगे पीछे की तरफ, तो उसको पेन होगा psoas टेस्ट. ओके, कोप psoas टेस्ट. रॉफ्सिंग साइन में लेफ्ट में प्रेशर डाल रहे हैं तो राइट साइड सारा कॉइल्स जा रहा है, उसके कारण दिक्कत हो रहा है. फिर आता है ऑब्ट्यूरेटर टेस्ट. पेल्विक अपेंडिक्स में lie on the obturator internus muscle. When this appendix becomes inflamed, internal rotation of the hip joint will stretch the obturator internus and the patient will whine in pain. Okay, Baldwin's test. Baldwin's test, a hand is placed over the flank of the patient. The patient is now asked to raise the right lower limb off the bed, keeping the knee extended. The patient will immediately complain of pain in case of retrocecal appendicitis. Retrocecal appendix remains in close contact with the psoas major muscle, which becomes contracted during flexion of the hip joint. In the passing, it must be mentioned that in case of retrocecal and pelvic appendicitis, tenderness and rigidity may not be that prominent on the McBurney's point. Here lies the importance of the above mentioned tests, which become positive in the retrocecal and pelvic appendicitis accordingly. Muscular rigidity में muscle guard. Muscle guarding is an excellent indication of irritation of parietal peritonitis. This may be due to inflammation, presence of blood, or contents of hollow organs within the peritoneal cavity. This is a part of the protective mechanism, which is also seen in the case of irritation of parietal pleura, which is restricted movement of the chest, irritation of the synovial membrane with restricted movement of the joint, and irritation of the meninges in the case of meningitis with rigidity of the neck. It is of utmost importance to differentiate voluntary from involuntary muscle rigidity. The involuntary muscle rigidity or muscle guard indicates underlying parietal peritonitis, the one which clinician is very much looking for. The voluntary muscle rigidity is simple rigidity of the abdominal musculature brought about by the patient himself to fear of being hurt and resentment due to exposure of the abdomen. During palpation, the hand must be placed flat on the abdomen using flexor surfaces of the fingers as the palpating media, and must not try to poke the fingers deep into the abdomen. Gentle movement of the straight fingers will be able to find the presence or absence of inflammatory muscle guard. This should be carried out all throughout the abdomen so as to detect localized muscle guard if present. फिर हो गया डिस्टेंशन, फिर लंप, और फिर हो गया पाल्पेशन ऑफ हर्नियल साइट्स. परकशन में फ्लूइड थ्रिल और शिफ्टिंग डलनेस देखोगे, हालांकि मेरे को नहीं लगता मिलता होगा. मिलता है क्या? प्रेजेंस ऑफ percussion should be done commence from the center of the abdomen is carried down to the one flank. At the point donors are noted, our finger is kept in the position and the patient start to turn the opposite side. And the body side is percussive for a few minutes. इसको कहते हैं shifting dullness. Fallacy enema may lead to abdominal retention, may lead to distension of the intestine. In these cases, the shifting dullness may be positive due to okay. Shifting dullness का खराबी क्या हो सकता है एनीमा में? गैस्ट्रिक एनीमा के कारण तुमको फॉल्स पॉजिटिव मिल सकता है शिफ्टिंग डलनेस. ओके, उसी को फैलेसी कह रहे हैं. फिर फ्लूइड थ्री का फैलेसी क्या है? कंसिडरेबल डिस्टेंशन ऑफ द गट एंड एम्फेसिमा ऑफ द लंग मे एबिलिटेट द नॉर्मल लिवर डलनेस. फ्लूइड थ्रिल हो गया. राइट मिड एक्सिलरी लाइन इज परकस फ्रॉम अबव डाउनवर्ड्स. द परकशन नोट विल बी रेजोनेंट इन द अपर पार्ट ऑफ द मिड एक्सिलरी लाइन. At the upper border of the liver, the resonant note is placed by the dull note if the presence of free gas under the diaphragm as occurs in the perforation of gastrointestinal tract. It must be remembered that the absence of this sign does not include perforation since okay. Auscultation में क्या करोगे भाई? ये क्या है? जनरल एग्जामिनेशन. अच्छा, फालतू फालतू चीज़ जैसे कि स्पेशल इन्वेस्टिगेशन में क्या करोगे? ब्लड को करोगे, ल्यूकोसाइटोसिस, शुगर एंड यूरिया एस्टिमेट्स, सीरम एमाइलेज सोमोग्रीन यूनिट्स होता है. अच्छा ओके. फिर हो गया सीरम बिलिरुबिन, यस. फाइब्रिनोजन, प्लाज्मा फाइब्रिनोजन, डीऑक्सीराइबोन्यूक्लियस, ल्यूसिन अमाइनो पेप्टाइडेज, लिसिथिनेज, ब्लड प्रेशर, यूरिन, एक्सरे, एक्सरे में गॉल स्टोन्स दिखेगा, रीनल कोलिक, अल्सरेटिव कोलिक, इंटोसिसेप्शन दिख जाएगा. Acute pancreatitis, gas in the duodenum and first coil of jejunum is may be sometimes seen. Stewart sign क्या होता है? gas filled hepatic and splenic flexure. Okay, no gas in the transverse colon is suggestive of this condition. इसको कहते हैं Stewart sign. एक्सरे में दिखता है. Okay, then एंडोस्कोपी में क्रॉन्स में क्या दिखेगा? प्रोक्टोस्कोपी में क्या दिखेगा? एनीमा. ओके, ये हो गया एक बार acute abdomen के causes. डिफरेंशियल डायग्नोसिस में क्या हो गया? इन्फ्लेमेशन. ये क्या है भाई? परफोरेशन, acute intestinal obstruction और हेमोरेज एंड टॉर्शन. एक्स्ट्रा abdominal causes भी हो सकता है. भाई बहुत ज़्यादा है.